Il me fait plaisir de vous présenter notre premier panel. Depuis plusieurs années au Canada, comme ailleurs dans le monde, les partenaires de la santé ont dû innover afin de lever les barrières à l'accès aux services de qualité et sécuritaires dans la langue de choix du patient ou du client. Parmi ces innovations, la mise en place de normes d'accessibilité linguistique apparaît comme une solution prometteuse. Une entente a été conclue entre la Société Santé en français et l'Organisation des normes de santé, Health Standard Organization, HSO, la filiale de développement des normes d'agrément Canada, afin de développer une norme d'accessibilité linguistique. Grâce à cette entente, une norme sera développée et rendue disponible pour les établissements de santé en 2018-2019, et cette norme agira comme un important levier afin d'emmener les établissements à intégrer des pratiques d'accessibilité linguistique comme gage de qualité et de sécurité pour la population de langue officielle vivant en contexte minoritaire au Canada. C'est le fruit d'un travail de plusieurs années du côté de la Société Santé en français, appuyé de la Société Santé et mieux-être en français du Nouveau-Brunswick, d'un comité de pilotage formé de direction générale de nos réseaux et de plusieurs experts des plus engagés. Les panélistes font partie de ces experts et nous vous partageons leur vision et leur expertise au regard de la transformation des systèmes de santé pour offrir des services dans un contexte linguistique minoritaire. Je vais maintenant vous présenter nos trois panélistes. Donc, la première personne, c'est Mrs. Guerful Roberts. Donc, Mme Roberts comes from Wales, and elle a une maîtrise. Elle est maître de conférences à l'École des sciences de la santé de l'Université de Bangor, au pays de Galles. Elle est à la pointe des efforts visant à promouvoir l'usage du gallois dans la recherche et l'éducation en santé et à appuyer la transformation des organisations sur le plan de la sensibilisation linguistique. Ses travaux de recherche s'intéressent aux moyens de faciliter l'accès à des services en langue galloise et de soutenir la planification et le perfectionnement de la main-d'œuvre dans un contexte de soins de santé bilingue. Guerful a beaucoup publié dans le domaine et elle collabore à la question du bilinguisme dans le secteur de la santé avec ses collègues du Canada, du Pays basque, où elle donne des conférences devant des publics internationaux. C'est une amie aussi de la santé en français au Canada. Donc, j'inviterai Mme Roberts à venir s'asseoir ici. Ouais. Dr. Aitor Montes, du Pays basque d'Euskadi. Dr. Montes est originaire de Bassori, au Pays basque espagnol. Dr. Montes est bilingue et a pour langue maternelle le basque et l'espagnol. Après des études de médecine à l'Université du Pays basque, il s'est spécialisé en médecine familiale et communautaire à l'hôpital Galdacao. Il travaille comme généraliste à l'unité des soins intégrés de l'Osakidetza, qui est l'organisme sanitaire basque dans le comté de Debagoyena. On ne m'a pas donné la tâche facile. I hope I say it well. Il est promoteur de l'usage du basque dans la prestation des soins primaires aussi bien qu'hospitaliers, conformément au principe d'une prestation centrée sur le patient, sachant que l'usage du basque constitue un enjeu sur le plan de la sécurité et de la qualité des soins. On a appris ce midi en parlant que Dr. Montes est l'un des rares médecins qui rédige toujours ses notes cliniques, ses dossiers cliniques pour ceux de ses patients dans la langue de leur choix. Donc, dans la langue, soit le basque, soit l'espagnol. Et il signe aussi des articles d'opinion dans divers quotidiens en basque et en espagnol. Donc, Dr. Aitor Montes. Okay. Madame Leslie Thompson, du Canada. Donc, Madame Thompson est la force motrice derrière le mouvement People Powered Health, déclenché par Agrément Canada et toute la nouvelle organisation des normes de santé. Après avoir été nommée PDG en 2016, elle a dirigé une consultation mondiale de 12 mois et un processus de conception opérationnelle. Avec son équipe, elle travaille maintenant à mobiliser la puissance et le potentiel des gens partout dans le monde qui partagent leur passion pour l'atteinte de soins de santé de qualité pour tous. Ses racines cliniques en tant qu'infirmière autorisée, continue à exercer une influence sur son incessante poursuite de la qualité et de la sécurité dans les soins de santé. Elle est aujourd'hui reconnue à l'échelle internationale pour son travail au chapitre du partenariat avec les usagers pour améliorer les résultats. Grâce à tout ce bagage, Mme Thompson est la bonne leader au bon moment pour HSO et Agrément Canada, deux organismes en mouvement qui mettent au point des normes mondiales en matière de soins de santé et des programmes d'évaluation novateurs qui permettent aux gens de sauver et d'améliorer des vies dans leur milieu de travail. Madame Thompson. Good afternoon and welcome to the rendezvous. We would like now to each of you to explain to us the context of and strategies of your respective countries or perspective of Accreditation Canada regarding the linguistic issues. And we're going to start with Mrs. Roberts.
Merci beaucoup. Madame et Messieurs, merci mille fois de votre accueil chaleureux. C'est un tel honneur d'être ici avec vous aujourd'hui. Diolch yn fawr iawn I chi am eich croeso cynnes, fel un sydd wedi bod digon ffodus I fod yma hefo chi yn Ottawa, yn y gorffennol. Mae'n hyfryd bod nôl yn eich cwmni. There's a little bit of a flavour of Welsh for you. And now I must apologise. Merci. But I must apologise now in turning to English because my French is not good enough. I didn't study hard enough at school, so I do apologise for that. So I thank you very much for your warm welcome. It's such an honour, it really is an honour to be here with you today. When Caroline Vezina kindly invited me to this conference, she explained to me that it was an opportunity to bring together a range of key stakeholders who are committed to enhancing linguistic access to health services for Francophone and Acadian minority communities, whilst hosting what she described as a family reunion. Now, in the short time that I've been here, I strongly sense that feeling of being amongst family and friends, a collective spirit and a passion that suggests to me that there's important work to be done, policy and practice improvements to be established, and inequalities to overcome. Now, thousands of miles away, in a country about 400 times smaller than Canada, in Wales, isn't it amazing that we share such similar experiences and commonalities? And these also fuel our passion in Wales to enable linguistic access to speakers of Welsh, the indigenous Celtic language of Wales, to enhance the quality of our healthcare services whilst protecting our safety, our dignity, and our integrity as minority language speakers. Now, in the bilingual context of Wales, where over 500,000 people, or 19% of the population, are Welsh-speaking, the Welsh language now has equal and official status with English. And the Welsh Government acknowledges that, and I quote here, strengthening Welsh language services in healthcare is now regarded as a priority, since for many people, language in this context is more than just a matter of choice, it is a matter of need. They proceed to explain that it's essential that there are no barriers to receiving services in Welsh, and that Welsh language services are offered proactively, widespread, and of an equivalent quality to those offered in English. Now, by But establishing the official status of the Welsh language has been a long and an arduous journey. Back in time, the exclusion of the Welsh language from public administration for over 400 years meant that the Welsh language became marginalised and the status of the language was eroded. And this situation, it had a detrimental impact on our attitudes as Welsh speakers and our confidence. And that in turn meant that we inherited a legacy of feeling inferior about our language. And that still contributed towards its rapid decline. Whilst over the years the changing political landscape of Wales has played a significant part in the revival of the language, as Welsh speakers we still experience discriminatory attitudes and language oppression, all of which have a detrimental impact on our readiness and our opportunities to engage effectively with healthcare services. Now, in spite of its troubled history, the devolution of Wales in 1999 has proved a significant turning point for the Welsh language, which is now at the core of our national identity, our legislative frameworks, and indeed our health and social care strategic policies. And the equality principle that's embedded in our Welsh Language Act of 1993 has been strengthened now in the Welsh Language Measure of 2011. And it was this that gave the Welsh language official status in Welsh alongside English and established the role of the Welsh Language Commissioner. It made provision for promoting and facilitating the use of the language, and it created a procedure for introducing duties on some organisations, including healthcare providers, in the form of language standards. Meanwhile, amidst growing concerns regarding the impact of failures to deliver Welsh language services in the health sector, particularly to vulnerable groups, the Welsh Government in 2012 published its strategic framework for Welsh language services in health and social care, and a follow-on framework then in 26, and it's aptly called More Than Just Words. This confirmed the way in which meeting the linguistic needs of service users is inextricably linked to providing good quality, safe and compassionate care. And the strategy itself, it's based on two very important principles. The first is the concept of language choice being replaced by a new emphasis on acknowledging the language needs of Welsh speakers who use our services. And secondly, adopting the principle of the active offer from your language legislation here in Canada, it introduces a new framework for identifying language need and then planning Welsh language services without someone having to ask for them, which means creating a change of culture that takes the responsibility away from the patient or the client or the service user and places that responsibility firmly on the shoulders of the service provider. Now, this calls for a responsive, whole system approach with an emphasis on mapping, planning, and developing the workforce, embedding strong leadership that steps up to the responsibility for meeting users' language needs. Now, we acknowledge in Wales that establishing such a significant cultural change is going to take time, and we recognise a host of ongoing challenges. But there are strong indications that we are making progress in the right direction. And this was particularly evident in our annual conference last month, an event similar to this, where health and social care stakeholders from across Wales came to celebrate successful initiatives and share best practice. And only a few weeks ago, a report published by the Welsh Language Commissioner suggests that Welsh services are improving and people are confident that their rights to use the Welsh language are starting to take root. Now, just to close, given the close parity of our linguistic experiences and their significance in providing safe, good quality care, I look forward very much to the presentations and discussions here over the next few days, which will no doubt fuel our determination and our resolve to take action. Diolch yn fawr iawn i chi. Merci beaucoup.
Thank you, Mrs. Roberts. Now, Dr. Montes.
Hello, bonjour. Je suis un médecin de famille dans les Pays Basques. Je ne sais pas français. Mon langue maternelle sont l'espagnol et le basque. Mais je ne parlais pas français, mais je parlais en anglais de souris aussi. So I have these papers to help myself if I have some doubts in English, okay? So, as she has pointed out, we have to take into account the context because there is not a standardized methodology to achieve language appropriate and patient-centered healthcare. So it's very important to take into account our context. I live in the Basque Country, and for most of you, the Basque Country is completely unknown. It is a stateless small nation located in Western Europe between France and Spain, straddling the boundary. So there is a northern France or French Basque Country, les Pays Basques, Saint-Jean-de-Luz, Saint-Jean-de-Puy-de-Port, Vaillon, and the southern Basque Country, the Spanish Basque Country, where I live. So we live under different administrations, like maybe the Kurds, for example, different states, and even within the state, different administrations. So we have le département de Pyrénées-Atlantiques, à la France. Le français, c'est la langue de la République, the only official language, so the Basque is not an official language, and it is out of courts, out of education, out of healthcare. And in the South Basque Country, we have two regions, or autonomous communities. Euskadi, the Basque Autonomous Region, where the Basque language is official, and in the east, Navarre, en français Navarre, la région de Navarre. Northern Navarre, southern Navarre, and it is only official in the northern part of Navarre, and not in the southern part. So we have a debated nation, a broken nation. I work in the Basque Autonomous Region, and that we have our own National Health Service. I mean, the regulation, the administration, the planning, the managing, the funding of health and social care is under the responsibility of the Basque Ministry of Healthcare, because we have our own autonomous or self-government. And we have an NHS system which offers public and free and universal access to every citizen. It's free. And in the last years, we work following the integrated care model through clinical pathways and through creating new organizations, healthcare organizations, merging hospitals and primary care units in single structure, single organization. So I work in an integrated care unit, or OSI in Spanish, ESI in Basque. I work in the Bagoiena Integrated Care Unit, which offers healthcare to a population of 67,000 people in a catchment area where 66% are fluent Basque speakers. And I work as a general practitioner in a very little town of 1,500 people in a circle of mountains, a lovely place, where 80-90% are fluent Basque speakers, and 70-75% use Basque on a daily basis. And every children, 100% of our children, attend primary school exclusively in Basque, and all of them are Basque speakers. Very important because they are our future. And I deal with my patients in two languages every day, in Spanish and in Basque. And I write the medical records in the patient's language of choice. It's very important. And so take into account that we are a divided nation, but it is not an official language everywhere. And to offer healthcare in patients' language, we have developed our Basque language schemes. Our NHS was created in 1983. Well, we achieved our autonomy or self-governance, I think it was in 1980. In 1983 was created our own NHS that considered that the first Basque languages scheme was launched in 2005 or 25, I don't know in English, 2005. So we have been 22 years late. And now it's working the second Basque language scheme since 2013. And well, just to remark that, well, we are promoting the language of choice of our patients, the preferred language. And now, since 2015, our patients can choose the language. And we work with electronic clinical records. We do not work with handwritten records. So when I deal with a patient, in the main screen of our PC, of our computer, of our application, I can see the E logo. That means that this patient wants to be attended in Basque. So it's very easy to identify our patient's preferred language. And I think it's very important to, first of all, to know our patient's needs or what they want. Just this. At this moment, it started 2 years ago, and at this moment, about 100,000 and 170,000 people have chosen the Basque as the language of use. Taking into account that is a very small country with 2 million people only. So in 2 years, 100,000 and 70,000 people have chosen Basque. But unfortunately, we have not grasped the concept of active offer. We have launched campaigns to encourage our patients to choose the language. But anyway, I think that it is not their responsibility. It is our task. So I think that an honest active offer will be that we should offer to our patients and the admission points or in our surgeries and our office to offer them the language of choice. Okay, maybe a question that is quite different is the language profiles. What is language competence? Language proficiency. So we have established 4 levels of language proficiency. First, second, third, fourth, of course. And it changes. We have our own assessments and our own requirements, and taking or considering the social-linguistical environment, how many people, how percentage of people speaks the minority language and where. And secondly, the health organization itself. I mean, it is not the same primary care, specialized care, or general services. So the first priority level is primary care, of course, nurses, general practitioners, and admission points. In admission points, the 100% of our staff must be bilingual. For example, the admission point of an emergency room. I work in a bilingual setting, so in the bilingual settings, we, the doctors, must achieve or fulfill the second level of language proficiency. That's very easy, anyway. And in primary care units, in bilingual settings, the 80% of the staff must be bilingual. Primary care, for example, dental services are quite different. They are not our priority, so only 40% of the staff in dental services or dental care must be bilingual in a bilingual setting, so it changes. We have to take into account the organization, primary care, specialist care, and the sociolinguistical feature. Okay, so these are maybe our differences. We are trying to establish bilingual pathways, full clinical pathways in the language of our patients from primary care to specialized. How? Well, just identifying patients' needs, of course, and then identifying and recruiting bilingual professionals. But it is only a proposal. We have established only one in my unit. This is my contribution, the urology service in Basque. So I even make the referrals, I write in Basque, and the urologists answer me in Basque, in patient's language, I mean. And well, our aim, our goal would be to establish in a second stage in the future the bilingual medical records. 2 years ago, or 3 years ago, we established a work group called the Bilingual Clinical Records Work Group to face this challenge. And our aim, our goal, will be to establish with the patient's preferred language registration and with the bilingual clinical pathways, and at the same time developing informatical or computer bilingual applications which enable the professional to use his or her language as a language of work, to transfer the language barriers issue from professional and or healthcare giver and user relationship to language barriers among or between professionals, because it is a responsibility and not patients. So it is our aim, our goal, but this is not, we are working on it and take into account that we face the same problems, because for most of our colleagues, this is not a priority subject. For my monolingual, I mean English speaker or monolingual speakers, professionals here in Canada or in Wales, or Spanish monolinguals, there are not language barriers. So well, more or less this is what we are doing in the Basque Country.
Thank you very much. Now we are going to go to Mrs. Thompson, who is the CEO of Accreditation Canada.
Good day. Thank you. Bonjour, everyone. And it is just a real pleasure to be here. And on the panel, I enjoyed your comments very, very much. And I have the privilege of, I want to give you a little bit of an overview about Health Standards Organization and Accreditation Canada and some of the work we are doing together with SSF to really make some very concrete and practical inroads into addressing the challenges that you are all speaking about today. At first, with the introduction, some of you may know well Accreditation Canada. Accreditation Canada has been around for 60 years, and now we have been involved in the accreditation of healthcare facilities in every part of the healthcare ecosystem, from hospitals, remote rural nursing stations, Aboriginal communities, health systems, primary care, long-term care communities, small diagnostic centers, everywhere where service is delivered, we are. And those assessments are based on a variety of standards. And when we went through our strategic planning just over a year ago, we came up with the realization that we needed to make the standards under which assessment programs were built much more rigorous and to raise the bar. Sometimes when you have the assessment body and the survey and the standards development in the same organization, you end up lowering the standards. And what we were finding is that people, when standards were getting too hard, they were saying, well, we don't need to do that, or let's lower the standard, or let's not put the stake in the ground of what the right thing should be. So what we've done is we've taken out of the national accreditation program, taken out the standards development role, and that is now in what is called Health Standards Organization, HSO. And HSO, why is this so important in Canada and beyond? HSO is now an organization by virtue of the way in which we will be developing standards. We have just been recognized by the Government of Canada as what's called a Standards Development Organization, an SDO. What does that mean? It means that the way we develop standards can then be designated as national standards of Canada. So why is this important? It's very important in the context of today, because as we, in our work toward helping to improve quality and safety, we understand completely and deeply the challenges that linguistic barriers can provide. In fact, we provide services in over 32 countries, and our standards are in 7 languages. But even though the standards are in 7 languages, we know the very real problem about access to services for linguistic minorities and getting access to service in language of choice is a very real barrier in Canada and beyond. So I am just so pleased to be talking about the partnership with SSF that actually started way before I arrived in 2014. And what we've done now is move toward the very exciting moment where we are officially now, as part of this new process of developing what will become a national standard of Canada, a very specific standard for that will be called Communication in Minority Language Situations in Canada. So and right now I'm very pleased that our distinguished panelists are participating in the technical committee that is meeting tomorrow, that is advancing this development of the standard. And this is a very important announcement I wanted to share with you, because this is now putting the thinking and the talking into action. And I'm very excited. Thank you. And with that standard, then if you imagine what that standard then, as it goes, what is in the standard? So it's, and we can talk a little bit about this throughout the panel, but there are some very specific things. So it's being co-designed with and sponsored by SSF, and what it's going to address specifically are what are those organizational structures and processes that are required at governance and leadership levels that support and ensure effective communication. So the organizations that would be assessed, and there will be self-assessment tools and assessment programs developed against this standard, they will need to demonstrate that they have the governance and leadership levels that support the effective communication and service planning in their data collection, development of policies and procedures. They must have adequate resources, staff education, and training. So you can imagine what our real goal is ensuring that this standard, when it's developed, is adopted and upheld in every single publicly funded healthcare service in Canada. That's where we're going to need, yes. We're going to need your help on that, because the ideal would be that this gets embedded in a legislative framework in every province where there is no opting out. That needs to be the real goal. But these also, and we will work toward and with our partners to move in this direction. And this will also, the standard is structured to influence right at that point of care, what is required, what conversations need to take place, how people assess the adequacy on the appropriateness of those services and at the admission, assessment, treatment, end of life, discharge planning, and transfer of care. So throughout the care continuum. So with this, there will be the standard, then there will be and that will take time. They're not going to finish all the work in a day. You are actually part of a technical committee that has 25% patients and users, providers, academics, international faculty. This is very much part of the robustness of the process. There will be public consultation on the standard, and that will be something that we will work together to ensure with SSF and others that there's great awareness of everyone about the standard so that they can comment on it and get the best of all of your input as well as it develops. And then once that happens, it's about an 18-month process. And then we as HSO will be able to designate that, if it, as the standard fulfills all its requirements, as a national standard of Canada, as an official SDO. And then we start on the journey of actually supporting the adoption and the effective implementation. But not to wait for that, we are working again in partnership with co-designing those self-assessment tools, co-designing the assessment methodologies so that by the time that the standard arrives, that we are ready to go and gets that all embedded in the system. There are many other things I can perhaps come back to as we talk because this standard is one of a number of standards that not only we want it standing on its own, to make sure it has an appropriate spotlight, but we want that embedded into the core programs and standard assessment programs that accreditation runs in Canada and around the world. As an example, our HSO standards have been adopted by the Netherlands, and they're provided in Dutch and French. For essentially the same assessment Cumentum program that is used in Canada is used there and in Brazil and in Kuwait. And what we want is now to make sure that all of those, as this standard gets developed, that it also will penetrate all those other countries as well, and we will work together to make sure that this standard that Canada is taking the lead on is adopted by not only every community in Canada, but around the world. Thank you.
Thank you very much. Isn't it music to our ears to hear that? I have a couple of questions, and we're going to ask if people have questions as well. My first question is, language barrier can be a real, even dangerous roadblock to integrate care with patients and families as full partners. How can we break down those barriers? Someone wants to start?
I was very encouraged to hear about Health Canada's investment today, to Louise Bouchard and the team, because I really feel that data is so vitally important here. Without data, we can't plan. We need that data in terms of the language profiles of our communities, but we also need data in terms of our healthcare professionals. So certainly in Wales, there's work to be done to map our regional language profiles.
I agree entirely with her. I think that, well, first of all, to identify our patients' needs or our patients' choice, what they prefer. This is, from the VASC perspective, the most important thing, to establish a registration of how many people want to be attended in Basque. The path was with the other one, but I think that maybe it's important to remark that, okay, to offer healthcare in patients' language is our responsibility as health professionals and organizations, but we need, or probably it is beyond our capacities and abilities. For one reason, we need to establish partnerships with communities the local communities or regional communities at all levels, but as well with institutions or administrations, especially with the education system. This is what we are doing, or what has been done in the Basque Country, because the greatest stumbling block to achieve healthcare in patients' language is the lack of bilingual professionals. How to recruit bilingual professionals if there is not a bilingual education system? So in the Basque Country, we have promoted, we are trying to develop a bilingual education system promoting the minority language. So I think it will be very important to offer bilingual education to every children and every young people in Canada. I mean education in English, of course, but as well in French at all levels. I think it will be very important to offer higher education, university, in two language as we have. At this moment you can study medicine, for example, only the first 3 years entirely in Basque, but you can study medicine in Basque and Spanish in the Basque Country. I think it will be very important to achieve exactly the same thing, nursery and medical schools in Welsh and English, and furthermore to embed the subject, the issue of language in education, in higher education, because the other stumbling block is the lack of language awareness. So we need, of course, to study medicine and nursery in French and English here in Canada, but to study as well as a compulsory subject how important the language is and what is a patient-centered care. So I think these are two good things. I mean, to identify your patient needs, to try to organize and recruit bilingual professionals to establish full clinical pathways in patients' language, but to work together in partnership with institutions, administration, policymakers, and education system.
Thank you. I've got maybe 2 points to highlight in this. One, to pick up on the education theme. I'm actually going to take home some homework based on what you have said, because we also have a very good announcement that went out yesterday. Lots of great things happening at HSO and Accreditation Canada. That Accreditation Canada will now be the official, we will be accrediting not only all the health services, but all the allied health education programs in Canada. So that means that basically all except for nurses and physicians and a couple of others, so paramedics and lab technicians and all of those education programs, we start in January of taking over a program that used to be run in a different way, and now we are the accreditor of choice, and they will be using, and we will be doing that. So I'm thinking, as you're speaking, boy, this standard, when you develop it, will be wouldn't that be interesting to link this, this standard around communication for minority language situations, not only in healthcare, but let's tackle, given that we're already accrediting all the education institutions, let's tackle that as well. So that is an opportunity. I didn't realize, I hadn't connected those dots yet, so thank you. That's very, I agree completely how important those connections are. The other things are that, that are just part of the standards that I think relate to the questions in a specific way is around interpreters. So there'll also be a fair bit of work in the standards around that, because it relates to access and the safety issue around the requirements for providers in terms of using interpreters, specific actions to ensure interpreter coverage at all points of access, at all times of the day and night, and to address what are the issues of using family members as interpreters, and there's all the issues around privacy and all the family dynamics and all of those things, and also the training and education of interpreters. So the technical committee will be tackling these issues and providing guidance on those. And I think that area is a really important one. And I know, having been CEO and led multiple organizations, of what a challenge it is sometimes to find the right kinds of services, and how do you do this well, not only in French and English, but in other languages as well. So the interpreter issue, I think, would be one I'd like to highlight as a challenge, and we're going to tackle that one as well with you.
Another question, in your opinion, what are the opportunities that must be seized in order to exercise a real change in culture and make the language a security and quality issue recognized and taken seriously? Would you like to start, Ms. Thompson?
So, culture is everything, and I think that's where it's going to take all of you and us and others who are really thinking about how do we create the conditions for the kind of the willing and enthusiastic adoption of these kind of standards, guides, rules, whatever, because even if we have all these things in place, nothing will happen if we're not capturing the hearts and minds of people and really creating the conditions for success with them, and make this part of just how we do things with patients and families. I do think, and very much again from my experience of working in multiple ways, one of the most powerful forces of change for in organizational culture are the voices of the patients and families themselves. And we've taken some very big steps of involving and engaging patients and families in everything that we do to ensure that kind of there's no room to kind of work around that. That's the center of who we are and what we do. And so we're now involving patients and families in the design of standards. Every technical committee will have 25% patients on it for every standard that gets developed from here in. We even now in the assessment of it will be of this standard as well as other care standards, patients as surveyors we are now training. And our first cohort, there are a significant number of French-speaking patients and family members who are part of that initial team that they will be part of surveying as well. And I believe that when you include the voice and the perspective of patients and families around almost any issue that is fundamental to quality and safety in healthcare, that the conversation starts to change and it becomes different when they are there. And I would say let us never be trying to do this alone, because this is very important.
Yes, I would definitely agree, and I would also add that the term you mentioned, winning hearts and minds, I think that's absolutely critical. And I would have another, perhaps a comment here, muscle in on change, because I think every change brings itself, it's an opportunity in itself, and we've seen some of those examples today. I just wanted to think, I was thinking too about some of the campaigns that have been successful over the years and what's made them successful. And it led me to think about a hand washing campaign that we had in Wales a few years ago, where that improved staff uptake and infection rates. And it was a very simple campaign. It used a sort of drip feed approach, posters, reminding people all the time. So thinking about that psychology really of how do you actually embed change. A lot of our university, we have a psychology department in Bangor University, and many of our young PhD students are actually looking now at issues around nudge theory to see how they can actually use that and embed that in these sort of situations. And perhaps I'd add one further concept here, was this establishing champions. Recognising champions, yes, who may be designated champions at a sort of higher level, but we can all be champions. We've got student nurses on our programmes who sign up to being a champion for active offer from year one, and they help us. They create their own videos, they create their own discourse, and they find that they go on their clinical placements and they make a difference. So I think it can happen at all levels.
Well, I think that everything is on our side, at least from the Basque and Welsh perspective. We have the legal framework. We have, even as you have pointed out, the opportunity to create new standards, for example. And a firm ground that is the new paradigm. I used to say that we now work in a patient-centered and integrated care model. So, well, I think that all we are here today agree entirely. We want to receive healthcare in our own language and want to offer healthcare in patients' language. But I think that our great challenge is to convince our colleagues, our policymakers, stakeholders, and managers. I mean the monolinguals, those who only speak English, those who only speak Spanish. So how to persuade these people? Okay, so I think that we have to change our mind. I think that to offer healthcare in patients' language offers us an added value as health professionals. Even we can be like bridges over troubled societies, at least in the Basque Country, considering our sad history and sad background. So, and even if you are a stakeholder and manager, this gives you the opportunity to achieve competitiveness, to become a leader, in this field. For example, well, you Canadians have been the leaders in the concept of active offer, de facto, for example. You have done a very magnificent research, and we the Basques have not brain. We have done research, nothing, but anyway, we have the opportunity of a strong arm, because we have in the next few years we will have available thousands of bilingual professionals to implement, to achieve a normalized healthcare. So I think the most important thing is to integrate this concept of adequate, integrate patient-centered care in the whole system at all levels. Users, health professionals, managers or stakeholders and policy makers. Try to convince them, okay? So I think that competitiveness, leadership, added value, things like this. And just to say that we have to change, and we need to change our way of thinking, and to change our practice. Just to finish, I will not say more because I don't speak English very well, but I would like to quote Musa Anter. I am Basque, and I come from a very conflicted background. We tried to rehabilitate, or to make the rehabilitation of our language many years ago in the 30s, but all this generation was martyred. The Basque poets, the Basque literatures were annihilated. Musa Anter was a Kurdish poet that was martyred only for his language. And once he said, if my mother tongue is shaking the foundations of your state, that means probably that you have built your state on my land. So we have to change, and our colleagues must change. I mean our monolingual colleagues, health professionals and managers. If our mother tongue, if our patient's language is shaking the foundations of your practice as a health professionals, that means that you have not strong evidence, you have not a firm ground. Maybe you have changed this evidence. Maybe you have new ways to look at the old evidence. Maybe you must speak a new idiom. This new idiom is the patient-centered care. So look to the language not as a challenge, not as a threat, but as an opportunity. Our patient's language should be, it must be a drive to achieve a work, perform, or to work better. Just I'd like to say.
Marc?
Presentation. Is it on? Yeah, okay. Thank you very much for your very inspiring presentation. I just want to talk about bilingualism. It's really important to talk about things being bilingual, but how about cultural sensitivity and cultural safety? Franco-Ontarians have been burned with bilingualism in the past few years, when the culture of the majority is still in place when you are in a bilingual setting. And I was wondering if you will be willing to go a little bit further in that, like talking about community driven by the Basque and the Welsh people, to have organizations that really reflect that cultural sensitivity and that cultural safety. It's quite important here in Canada. And bilingualism is a good answer to start, but having the organization taken in the hand of the people you serve can be a step further.
Absolutely, I couldn't agree with you more. And we do have organisations, Welsh medium organisations in Wales, who at different levels will challenge. And they have been very active and very successful in getting to where we are today. I'd just like to mention one organisation which has been tremendously useful for us since 2012 has been the establishment of the Coleg Cymraeg Cenedlaethol, which is funded by Welsh Government. It's a virtual university and it invests in Welsh medium projects, lectureships, any ways at all in enhancing opportunities for students in all disciplines across our universities in Wales to study in Welsh. So there's an example of an organisation funded by Welsh Government. Its organisational language and culture is Welsh. It produces documentation bilingually to assist everybody to understand, but it's firmly Welsh. So there are plenty other examples too, but we have pressure groups too. Everybody has a part to play. Yeah.
I can just add one piece with that I think is important, and again, I'm learning so much while I'm here and connecting some other dots, because another standard we are working on is actually around cultural safety and humility, and we're actually working very much in partnership with First Nations communities. As you know, this is a very big issue, an important issue for them. And but they've taught me early on that it's not just about Aboriginal people. It's a standard and a way of being that can apply well beyond. So I think that you're reminding kind of me of that importance from a variety of perspectives. I think that certainly from the standard of communication, we have to address that squarely. We can't dilute it. It needs to be really focused. And the other one, and then in organizations, it's about putting those things together to actually make it work for patients and families. But I really appreciate that kind of notion of thinking about this beyond language. So thank you.
Gilles?
Bonjour. First, Dr. Roberts and Dr. Lasarte, thank you very much for both your presentations. It's so nice to have people from other places in the world coming here, sharing your experience, and enabling us to look at ourselves through your eyes. And I've learned a lot too. I'm still finding the dots. I'm still not connecting them, and I'm still finding the dots. So thank you very much for your presentation. It was really enriching. Ms. Thompson, I have the pleasure of being on a team that has been working with Accreditation Canada and HSO for the past, well, it all started in 2010, before there was even HSO and before there was, the point I want to make is that in the last, well, it took us about 6-7 years to climb the hill, and we've been running after the car since then. Just like the dog story, you know. He runs after the car, and once he catches it, what the heck you do with it? And this was because this Miss Leslie Thompson came along and acted as a leader for the organization, turned it around, along with Sébastien Odette, did a tremendous job changing the culture of a Titanic, or still working on it. And that's why we're trying to catch the dog, because we were certain that the project that we have with SSF and Accreditation Canada, that I wouldn't be standing here today and you've been standing there at the front talking about it. I was looking at 2023 maybe, if we were lucky. And the point I want to make is that this is the same type of leadership that we will need in every jurisdiction in the country, from the people that are responsible of our health organizations. They have to trust themselves, they have to trust their staff, they have to trust their team, and even more so, they have to trust the community, because the communities will be there, the networks will be there to help with different tools. Every organization, health organization that would like, because I know they will all like, to be able to take the standard and challenge it and hopefully have distinguished recommendation after all. So anyway, I'm from New Brunswick. We're going to be probably the very first big target of those standards, because we're the only officially bilingual province in the country. And we're bounded by 2 laws in the province that every services has to be offered in the language of choice of any New Brunswickers, anywhere, anytime. It's always been the laws. Now we're going to see the laws into action, and I have one person to thank you for that, and it's you, Mrs. Leslie Thompson. Thank you.
Hi, my name is Pauline Babineau. I'm with Horizon Health Network in New Brunswick, also in New Brunswick, so it's very suited that I follow Gilles. I guess my question or comment is more directed towards Ms. Thompson, but I'd also be interested in what others have to say. In New Brunswick, again, to reiterate what Gilles said, both languages have equal status. So I guess my question or my concern is around the use of interpreters. In New Brunswick, we already use interpreters, but for other languages, so for foreign languages. And this has been our practice for several years already. But when it comes down to using interpreters for French, we've considered that, or we view that as an accommodation, where the law really states that we should be receiving services that are equal, without undue delay. So our goal is always to staff our teams and create linguistic teams that are readily available. But we also understand in the meantime, while we're working towards that, we do have gaps in the system. So we have our contingency plans, which we use, which can be staff from other departments or whatnot, but never really interpreters for French. So I'm just kind of wondering how you see that fit into the great Canadian landscape where New Brunswick has that particular difference.
I think thank you so much for that. I mean, that is precisely the issue and that's why I kind of said, when are interpreters used and how to meet this standard, the creation of this national standard. It's going to be the technical committee that will wrestle with these issues. And that they and SSF and others, that's going to be the saying, what should the bar be for this standard? And there will be also processes to make sure that people can add their voice to the to the work of the technical committee to make sure that it's reflecting the views and the values and where it needs to go. So we haven't written the standard and saying, here, could you look at it? This is a true evidence-based, informed, and what should the bar be for Canada? And that's what's going to happen over the next 18 months. And so your views and others will be very key. And in fact, one of the very interesting things and why I'm so excited about having become an SDO officially is this public consultation piece that's required. The members of the technical committee actually are obligated to review every single input from the public and document how they've considered that input in their ultimate decisions on the consensus related to the standard. So there'll be lots of opportunity for that kind of of input to be there. But what you say makes a lot of sense. But I'm going to be passing that to the experts to do this in a way that would far surpass anything I could ever do on my own. So thank you.
Madam Roberts.
Just very briefly, you've described a picture which is so common to us in Wales. It's exactly how we deal with our situation in terms of acknowledging that a bilingual practitioner, and the evidence, the global evidence shows, doesn't it, that bilingual practitioners are there to enhance the practice. That is our gold standard in Wales, so that's just something I wanted to add as well. And there are challenges, but we also follow those contingency plans that you talk about, and we take on board the way that the Basque Country demonstrates to us that it's through education that we can enable that capacity within our workforce in years to come, where we will have sufficient bilingual speakers to be able to actually put that active offer in place without needing to call on interpreters.
Dr. Montes.
Sorry. In the Basque Country, Basque and Spanish are official, and we have not interpreters because in one hand, for many professionals, there are no language barriers. It's not a priority issue. So, as in Wales, they used to say, anyway, they speak English, anyway, they speak Spanish. But take into account, well, our cultural background is different. And in the Basque Country, especially in pediatric care, sometimes health professionals try to use the relatives, the family, as interpreters. But it's happening in the last years. For example, I think it was last month, a strong, we had a problem in an emergency department because at this moment, many people refuses interpreters. They don't want interpreters in a bilingual context. They only want bilingual professionals. And when the pediatrician, for example, addressed to parents in Spanish, and then the parents addressed to their children in Basque, they get, the parents, get really angry. Angry, is it the same? Okay. And frustrated, and they feel themselves undeserved. So maybe is our perspective as a Basque country, as Basques, but they don't want at any moment any interpreter. They only want truly bilingual professionals. Language concordance is what they want. No, they don't accept. If you, for example, if you offer them an interpreter, you will have a bad answer. Be careful enough in the Basque country. Be careful if you offer an interpreter. Be careful. Be really careful. No, it's true. Last month it happened in the Basque country via Twitter, via WhatsApp. It spread like fire. The protest, the complaint of a father who attends an emergency department. In this emergency department, there were at this moment at least 2 Basque fluent speaking pediatricians. But unfortunately, we have not one thing. We have not standards, we have not protocols, and we need them, and we need to work together for this reason. Unfortunately, at this moment, there was not any standard. So this child, 3 years old, was attended by a Spanish monolingual pediatrician where at this moment there were 2 Basque fluent speaking pediatricians. So it ended like Waterloo, so to speak. And a lot of complaints in Twitter, WhatsApp spread like fire, and we have had many problems. So, really be careful.
I was just going to say, I think it's the challenge, I guess, is going to be to balance out in the different environments, because what we know is one size doesn't fit all. So where there is the access to those specialty and bilingualism that's the standard and it's there. But if you're in a remote rural community, what are the ways in which you can feel like you've got equal access to that language when the person may not be physically present. I think we're going to need to be imaginative and think about the way we handle, and this may not come across right, but handle like people with rare diseases or others where you have to have access to the specialists as if they were there right in your room. I don't know if it's telemedicine, I don't know what the ways are, but nobody should be disadvantaged because they can't access, but you may not be able to have the same resources you have in Montfort Hospital in a small rural community in Alberta, but where there are still French-speaking people. So those are the challenges that you're going to need to be tackling and coming up with what the standards should be.
Il y a 4 personnes au microphone. There are 4 people at the microphone, so we are going to try to speed up a bit. Madame Cardinal, Monsieur Castonguay.
En fait, M. Castonguay est avant moi.
OK,
Donc,
Monsieur Castonguay.
mais on peut poser nos questions en rafale, un après l'autre.
Mais que vous êtes gentil, Madame Cardinal. Yeah, my comment is addressed to Mrs. Thompson, and I come from the perspective that I'm a community primary care agency that is accredited by Accreditation Canada, so I am aware of the process and some of the standards and everything else. All that to say that in Ontario, we already do have standards for French language services, and it's called the French Language Services Act. And in 30 years of existence, okay, the government has not been able to get many of these agencies, especially in the health field, okay, to basically live up to their responsibilities and their obligations under that act, in spite of accountability agreements with local health integration services network or directly with the ministry. And so I guess when I hear you say that Accreditation Canada is now going to start developing standards, and we start talking about the concepts of interpreters being introduced into those standards and all that, that scares the bejeepers right out of me. And basically, it points us on a very, very, very slippery slope. And I'm going to explain why. Because if you are developing standards whereby you're accepting interpreters as being an acceptable form of delivering health, or for any kind of French language services, for any kind of French language services, I can tell you as a Francophone, I find the concept of receiving services through an interpreter not only unacceptable, but quite frankly, offensive. And I don't think that we should be promoting that. Okay.
So,
but just a second. The reason that I say that we're on a slippery slope, okay, is that in 30 years of existence, okay, the government has never put enough teeth in the legislation or in their accountability agreements with agencies to force these agencies to live up to their funding obligations. And we know that Accreditation Canada has no jurisdiction over accountability or the funding agreements that keep on funding these agencies. And so if Accreditation Canada, okay, is not very stringent and very, very determined, okay, in the accreditation process, many of these agencies are going to continue to receive their accreditations and sort of use that as a blank check before the government, saying, say, you see, we're reaching our standards. And the standard maybe not be exactly what is the hopes and the aspirations of the Francophone community, or even what's expected of these agencies in their accountability agreements. So I would be very careful, to put us on that very slippery slope. And I hope that if there are standards that are going to be developed, because they probably will be, that it becomes obligatory standards. Not standards that it's one of these where, you have to respond to 3 out of 5 or 4 out of 5, but that these standards become obligatory standards so that agencies have no way out of this. That, they either meet it or they don't. And if they don't, then what happens is that it should be validation to the government that, these agencies aren't living up to their obligation. Government, you're not getting the bang for your dollar, and you may want to be looking at other strategies.
thank you so much for those comments. The first thing that I want to, and maybe I kind of turned my notes and I might have missed what I have described as dealing with the issues of interpreters and when they're appropriate, everything else will need to be addressed in the standard. Please don't interpret that is the standard in the situations that might make, that you're expressing as wouldn't be appropriate. This is what the work of the committee and the technical committee over the next 18 months is to develop, and we've come together with SSF to who has said, we're sponsoring the development and we want this national standard of Canada. And then it will be up to the technical committee to be looking at all these issues, plus people involved, and to get the best knowledge to say, this is what it should be. This is the bar. And I think that I have great confidence when I look at the high quality of people, and knowing that all of you will take responsibility of making sure you're putting your voice in there too, that we will have a standard for Canada that makes sense, and it needs to be something you are extraordinarily proud of. That's going to be a big measure of success. And then the issue around the standard is one thing, and then it is how is it upheld. There are examples in provinces and in other countries where certain standards are referenced in legislation and saying that as a condition of funding, you have to meet that standard. So we have that for some areas of labs and technologies and other things, your electrical outlets, some of these things. So there are ways to get at the obligatory piece. I think that's going to be part of the discovery and the work we're going to do over the next 18 months together to figure out what those levers are to support. But, and to make sure, ultimately, the goal is to have a standard that all of you, I would think, are such important stakeholders that you stand behind and say, this is adding value to the people we serve and ultimately to our communities. So I appreciate your comment and your caution, because that's something that needs to be taken into account.
Okay, Madame Cardinal.
Well, I just want to reinforce what my colleague just said. For me, the standards are very important, but you keep on referring to the technical committee. It's not a technical issue, it's a political issue, and it's a strong political issue, because in this country, we are a federal system. We have 13 legislations. And so there is not just one bar for health issues in Canada or health standards. You have 13. So how are you going to maneuver so that your standard can also be put in a way that will not undermine legislative frameworks, that can serve as a lever for reinforcing, just like Marcel was saying, reinforcing perhaps accountability within the different provinces and region. And you're a non-elected body, so how are you going to be accountable, and why should governments be accountable to you?
So again, great questions, and this just shows that we're on the right track, because there's a lot of challenging issues. One of the issues is now that we are designated by Government of Canada as a standards development body, and that's new for healthcare. Healthcare's never had, there's never been an SDO that's dedicated completely to health and social services, and so with a mandate to develop standards for health and social services in Canada that, by virtue of the process, are national. We don't say, we're not the ones that say you have to use those. HSO is producing those, and then there's a variety of the other mechanisms in place to deal with who adopts them, how they're enforced. And what we're doing through this process is developing tools and ways for that to become widely adopted and so forth. So that's, it'll be a journey, but there's many examples of national standards in other industries and that are produced by HS or by standards development organizations. And now healthcare has one, and this is a big positive thing. And I can tell you that Health Canada and the provinces are very, very excited to have this as an opportunity of something they can rely on as they work in their own jurisdictions.
Dr. Montes.
In the Basque Country, we have a strong legal framework that compels us to offer healthcare in patients' language, but unfortunately we have done nothing. So, well, looking ahead, I think that we have an opportunity to work together, the Welsh Canadians, and we have in mind to create a new Basque scheme in 2018, and until now, all our Basque language schemes have been aligned with the legal framework, but without research-based evidence, without work or with communities. Only Basque language officers have done this Basque language SIMs, not health professionals, not patients. So, well, I'm optimistic because I think that in the very short future, we will make a new Basque language scheme, but we have to take into account, as you have done, the patient's perspective, the point of view. And I think that in parallel with the legal framework, align it with the Basque language scheme, we could do new standards focused on the Basque perspective with your help of the French community, with the help of the HSO, and why not to make standards that must be fulfilled for one reason, to make pressure to our monolingual colleagues, because otherwise they say, okay, that is delay the legal framework, but we cannot achieve this. No, it is the legal framework, of course, but at the same time, you have standards to fulfill. So, okay, in this way, I'm optimistic. And next month, well, I'm here now in Canada, but last week, for example, I used the telephone. The telephone is a thing that you can use to make calls, not only to send WhatsApps. So, I called to my central services, and I spoke with the secretary of my boss, the boss, God in heaven. So I've called them, my bosses, to make a meeting, to meet with them, to talk about this, and how to implement for the next year the full clinical bilingual pathways. I say we have the Canadians with us in our side, we have the Welsh, we have the HSO, we have the SSF, we have the evidence, we have to do it anyway. And we have an opportunity, because we have a strong bilingual staff, we have the opportunity to be the leaders in this field, in bilingual health services. So I will give them this option. Otherwise, in a bilingual context, like our context, where the language is very well linked with identity, we are going to a social conflict. So I, in this way, optimistic. Why not? A new Basque language scheme, maybe a new legal framework, but at the same time, standards. Why not? Why not? And to work together. We will move faster if we work together.
Les gardiens du temps sont sur mon dos, ils m'envoient des messages. Alors, il nous reste très peu de temps. Je vais demander à Mme Thibault et ensuite M. Djembas.
C'est pas Djembas.
Non, OK. Si vous pourriez, si vous avez des commentaires.
OK, vite fait. I think the one thing I haven't heard yet, and I'd like more conversation on, and we don't have time, is, and it was named when Dr. Roberts talked about almost obliterating a community because of their language and culture, and we've seen similar things in Canada. And the other piece about data. So we have a lot of resiliency in our minority communities, but we need to spend time on standards and quality care, but we need to look at our community. I hear a lot about patient-centered. I'd like us to talk about people and community-centered and prevention and promotion so that they don't make it to the end service that they may not have needed if they had a healthy community. So I know I'm accredited by another accreditation that really looks at our community governance, that looks at how are you engaging the community to be healthy, because if our communities are not healthy, they're not going to be healthy. So I'd love it that if we could have more conversation and standards in that area, because I think it would support, especially those of us who are in minority populations, communities.
Merci.
My name is Dieudonné Bello, not Monsieur Djembas. I am the French language coordinator and indigenous health consultant at a local health integration network in the Central West Lane. As Canadians, we are proud to have across Canada high quality medical school across the country. And when you have a conversation with a health service provider regarding active offer, one of the challenges they state is that we don't have the health professional bilingual resources to offer the services. And we know in Ontario, more often there are a lot of health professionals, bilingual health professionals coming from other provinces. And they face a lot of barriers to integrate the healthcare system in Ontario. This is one thing. On the other hand, we have also health professionals coming from immigration. And we can find this health professional from immigration in other healthcare setting, working in other field as health promoter, or you can find them changing career because they cannot integrate the health system as professional. My question is for Madame Thompson. First, how do you see Accreditation Canada reducing barrier for health professionals who receive their education in Canada, wherever they come from in the country? How do you see reducing the barrier for them? Because a lot of French language bilingual health professional is there in the province, but they face a lot of barriers to practice. How do you see reducing this barrier for them? And for immigration, I am just finishing. And for immigration, how do you see a framework to support health professional immigrants who are not providing, who are not exercising in their field of education when they can be a big resource for our country? Thank you.
Those are challenging questions.
Yes.
That I think are the kinds of ideas that are really important as we look forward, or what are the other kinds of standards that might get developed or be sponsored to be developed. And so I think that that's something to potentially consider. And I do think that my distinguished colleagues have already, I think, mentioned the importance of the role of the professionals and where they fit in this access to or supporting access to language in minority language situations. So I think that will get covered. Some of that, your points, will get covered in the development of the work that is underway with this standard, and others are beyond that scope, that are not within the work that we do today. But with all the right partners, we're there to look at what else we can do to support the kinds of access issues you described. Thank you.
Merci beaucoup. Merci beaucoup à nos trois finalistes. Merci à tous ceux. Alors, merci. Thank you very much. Thank you, Mrs. Roberts. Thank you, Dr. Montes. Thank you, Madame Thompson. Merci aussi à tous ceux qui ont posé des questions. Ça faisait partie du débat. Je pense que le rendez-vous est bien parti. On va continuer la discussion ensemble. Et je redonne la parole maintenant à Véronique.